Today, we welcome to our show Dr. Mathew Leonardi, a specialist in complex gynecology and ultrasound with a focus on endometriosis. He is Assistant Professor at McMaster University, and he's an Honorary Adjunct Lecturer at Adelaide University and an Honorary Associate Professor at Western Sydney University. Dr. Leonardi is a nationally and internationally recognized leader in his field. He has published over 120 peer-reviewed scientific articles, several textbook chapters, and presented globally on complex gynecologic conditions and ultrasound. He is also on the World Endometriosis Society Board and a founding member of the Next Generation Committee at the International Society of Ultrasound in Obstetrics and Gynecology. He's an associate editor for Reproduction and Fertility, and he's also on several editorial boards for other leading journals. March is Endometriosis Awareness Month, and we wanted to bring him onto our show to spread knowledge and insight from such a fantastic expert.
Dr. Leonardi, thank you so much for being here. And I get the honor of asking you the first question. So for listeners who are newly diagnosed with endometriosis, tell me, how do you explain it to them in a way that it's simple and it makes sense? Please explain why it is so misunderstood and missed for so long for so many patients.
Great to be here. Thank you so much for having me. It's really nice to see you, Marta, after so many years, and it's nice to be able to see you both face to face. Obviously, I received lots of requisitions from you with the request to identify endometriosis and other gynecologic pathologies. So let me start with the second part of that question. Why are we dealing with such an enigmatic disease with respect to endometriosis? There's so many social reasons. Women have gone decades and centuries without being heard, being believed when it comes to their health experiences. Women's pain in particular is often not believed. And I want to be cautious up front to acknowledge that endometriosis is a disease that doesn't just affect women, it affects individuals who are assigned female at birth, who have different gender identities, transgender men, and those who are gender fluid. And so it really is a disease that has evaded lots of parts of our society because historically women did not have a chance to have a voice. And there's so much dismissal around pain as normal, as this is a part of a woman's life. And so I think that the biggest issue is recognition up front from the patient's perspective, from their family's perspective, from their primary care provider's perspective. It even gets into degrees of employment. Employers don't necessarily see this as an issue for their employees. That's why I think primarily we are where we are with respect to the recognition of endometriosis. But part of the issue that we face is historically the only way to diagnose the disease was through surgery. So a lot of people didn't get that diagnosis. When I diagnose people through imaging, and we'll talk lots about that today, I tell people this is a chronic disease. This is technically an incurable disease. It's a systemic inflammatory disease. We now realize that this is not just a gynecologic disease. So what that means in a lay fashion, this is a full body disease. This is a disease that affects your pelvis. It can affect your abdomen. It can affect your brain. It can affect your mood. It can affect fertility. It can affect things so far reaching that it really is not just a gynecologic disease. Endometriosis is tissue that is abnormally placed in the body. So the tissue is very similar in cell type to the endometrium, which your patients who are listening to Fertility Podcast will know is where the pregnancy will implant. It is tissue that is similar to that tissue, but it is outside of the uterus that grows anywhere in the body. Primarily, it does grow in the pelvis. It can grow on the ovaries, in the ovaries, on the bowel, in the bowel, anywhere in the pelvis, but it can also be found elsewhere in the body. And in fact, it has been identified in every single organ system in the body through case reports published in the literature. And it exudes or it gives off inflammation. It also causes adhesions, which means organs can get stuck to each other. They're not supposed to be. And so that can create abnormalities in how a person's pelvis or abdomen looks like, and that can change the function of those organs. So, for example, the bowel or the fallopian tubes won't work properly. So I think that's my best way of describing endometriosis in the most lay terms possible.
Thank you so much for highlighting the under recognition of pain and really what their experiences in terms of endometriosis are, because I think that this is something that is across, so many different medical conditions, not just endometriosis, where we often under recognize or underemphasize the pain that some women are experiencing. And not just endometriosis, but of course, that's the context of our conversation today. I really feel like over the past few years, the recognition of endometriosis and of what it means to a person in their life, not just the extent that you might see surgically, is really being much more recognized and being brought to the forefront more than ever before. It's so fabulous, of course, that this episode is coming out for Endometriosis Awareness Month. And we wanted to talk to you and have you on the show so desperately to talk about exactly that and to talk about it, especially from this fantastic perspective that you have. Of course, this is a fertility podcast, since I really want to get into the fertility stuff with you. That's going to be our main focus. So when patients ask you about endometriosis and fertility, how do you explain the relationship, or how do you talk about it? How does endometriosis potentially affect fertility?
Endometriosis is definitely one of the most common diseases that causes infertility. We have evidence from really landmark publication in Fertility and Sterility that says if a female patient has a male partner with normal sperm, the likelihood of endometriosis as the cause of infertility is roughly 50%. That is really, really high as a cause for infertility. And amongst those who have endometriosis, who are not yet trying for pregnancy, we have estimates from the literature that suggest about 1/3 of those patients will eventually experience infertility. Of course, 2/3 will not. And that's great news overall from a statistics perspective, but 1/3 is still a large proportion. So I frame this in sort of two ways. In the patient population who is currently experiencing infertility, I believe wholeheartedly that endometriosis must be at the top of the list of diseases to evaluate for, even if there are other known causes of infertility in that patient. For example, our team is doing lots of work showing overlap between PCOS and endometriosis. So, PCOS also comes along with lots of controversies around diagnosis. But if somebody walks into your office with a known diagnosis of PCOS, that does not mean we should not be looking for endometriosis as well, since when treatments are offered, they need to be refined to that individual. And a PCOS endometriosis combination is going to be a different treatment algorithm than PCOS alone. So I believe that every patient with infertility or fertility struggles really does warrant a very refined evaluation of endometriosis. In the alternative population of those who get a diagnosis before they're seeking fertility, I really think about the extent of that disease using imaging and try and cater my counseling to them around either some degree of reassurance if the overall architecture of the pelvis is quite normal, there's no endometriomas or major adhesions, which would impact on what we call the Endometriosis Fertility Index score. Or if there are endometriomas and somebody has a hope for fertility, I get those people to a fertility team immediately to start discussing fertility preservation, because we know the damage that endometriomas and endometriosis can do. And I at least want to give people that opportunity to have counseling from the fertility doctor perspective around what does it mean to have preservation? What does it cost? What are the likelihoods of success if you use those eggs or embryos in the future? So I get those people straight away. So I'm very, very prophylactic or sort of active, proactive in my approach when it comes to patient diagnosed with endometriosis who is not yet seeking fertility but wants to in the future.
Yeah, so absolutely. That is great. And let's talk a little bit about that. So let's say patients are early in the fertility journey and maybe they've been trying for a few months. Maybe there's male factor or PCOS, as you mentioned. And I agree, there is value in having all the cards on the table before we start the fertility conversation. And endometriosis is definitely on that list. Now, like Dr. White says, this is a fertility podcast. So fertility is going to be a big part of this conversation. I think it's really important to remind patients that even if they have endometriosis, they could still conceive naturally. And they can also be offered the standard treatments in fertility care, such as like IUI, which is an entry-level fertility treatment, and IVF with embryo transfer, without necessarily having to go into surgery on having to do these advanced protocols like lupus suppression for 3 months and whatnot. So I know that this is more like what we do versus what you do, because you diagnose the endometriosis and we treat the infertility. But can you talk a little bit about patients being diagnosed with endometriosis and then all of a sudden they feel that they need to have this big surgery before they could even try having a baby?
Yes, for sure. When we assess somebody with ultrasound, we are able to identify all the various subtypes of endometriosis, including deep endometriosis, superficial endometriosis, ovarian endometriomas, and then not quite a subtype, but a consequence, which is the adhesion state, when the organs become glued together. And I really refine my counseling around the approach to the patient. And that often for me involves their symptoms, more pain-related symptoms. But if they're actively seeking fertility, that comes into the conversation, whereby if a patient has complete obliteration, which means from a medical term, severe adhesions, everything is very, very stuck. There may be fallopian tube abnormalities like a fluid hydro or hematosalpinx. I tell these people, no matter what I do surgically, I won't be able to overcome your ability to, your desire to conceive naturally. This is a direct line to fertility clinic and, generally speaking, direct to IVF. So I use the imaging to help me decide what strategy clinically should be applied. When people are having the more subtle forms of endometriosis, for example, superficial endometriosis without the other forms, without any adhesions, and let's say they're in their early 30s, as an example, I think that that's a good patient population to consider surgery for. They have time. They have, generally speaking, relatively good egg reserves. They have a disease state that is actually manageable from a surgical perspective, whereby you can remove the disease and ideally leave the rest of the organs in very good shape. And so I might cater that conversation to that patient to say, you might not need IVF or you might not need IUI. You can consider it, certainly, and a referral to fertility is still something that we do very readily. But surgery actually kind of comes up a little bit higher on the list of options that might be useful for them for that goal. But when people say, just blindly, oh, I have endometriosis, I need surgery, and then I will get pregnant, that just lacks so much understanding of the complexity of this disease. And I fear that social media has led to an oversimplification of a really, really complex subject matter, that somebody hears something online and then they think, well, that must be the truth because an expert is saying it, and that must apply to me. So I just need to find the right person to do that surgery, and therefore I will conceive thereafter. You really have to sit down with the expert in the office and dig in to the nuance of you. It's not just about endo and the stage of endo. It is about your age and your past experiences and the comorbidities, meaning the other things that may be happening in your body. Is there thyroid issues, PCOS, adenomyosis, polyps? There are so many other things that can happen. And the individualized approach is really key. And for me, the ultrasound is the biggest player in refining that individualized piece. For me, it has revolutionized the approach to decision-making in gynecology and in fertility care. And I think that we have a lot of optimism for the coming years, because right now a lot of gynecology and fertility care is still relatively fundamental. It's relatively algorithmic, if you will. We follow lots of guidelines, but I think the imaging can provide a lot more nuance to help us figure out which treatment option is the best for that person.
Absolutely. I mean, I think that the message, the thing that we are always talking about ad nauseum, and I think that what you've brought up multiple times as well, is that individualization to the patient, having that discussion with the patient, the shared decision-making model, working along those lines is so, so key. And again, another key point that we always talk about is what are the bigger family goals, right? I mean, we're, trying to aim for one child or hoping to have multiple children. And what are our timelines like? Because in all of this, we also have to consider the reality of the Canadian and the Ontario healthcare system in which we practice, where, on one hand, we talk about these ultrasounds, we talk about surgeries, but accessing these things and actually getting the imaging and getting the treatments done can be challenging. Surgery, endometriosis specialists really should be the ones who are performing these complex surgeries. And unfortunately, we have to be very realistic and have real conversations. We love the idea of surgery and doing this, but it's going to take some time for you to see the specialist, to be on the wait list, to actually get the surgery done, because we know surgical wait lists are very long. In the meanwhile, do we move forward with timed intercourse cycles or maybe IUI? Or maybe we should be thinking about doing IVF and making embryos and storing them for future use. And then, of course, another big piece of this puzzle, especially when we're talking about fertility, is cost. Because there are real financial considerations, financial ramifications when we're talking about these things. And I think in the world of fertility, it's something we're always talking about, right? And in a way, we're budgeting, frankly, right? We're budgeting time, time to surgery, what can we do in the meanwhile? And we're budgeting money. And those are some very challenging conversations and probably some of the most challenging that we have. In an ideal world, I would love to be able to offer fertility preservation to all patients with endometriosis so they can get their surgeries done quickly, expediently by the people who are the experts. But unfortunately, that's not the reality that we're working in. And so how do you address that? Or how does that play into the counseling that you do or the shared decision-making that you do with your patients?
It's such an important point you bring up. The truth of endometriosis is that you didn't do anything to deserve it. You didn't cause it. It is just a disease that you unfortunately got. And we have to accept that it's going to change the reality of your life. And I have realistic conversations with my patients to say, aiming for a pain-free life is probably not a realistic goal. We need to aim for optimization of your quality of life, your pain scores, your function. And it's a really unpleasant reality for people to face, because we're talking about 20-year-olds, 30-year-olds. These are people at the prime in their life that want to be able to do whatever they want to do without limitation. But unfortunately, endometriosis has come into their lives. And I think from a fertility perspective, that facing reality has to be part of that conversation. If somebody wants 3 children, 4 children, but you have endometriosis, maybe that goal needs to be thought of a little bit more and try for the first and then maybe go for the second, right? Because it is there. The disease is there. And even if it's a mild form, there's still optimism, but it's still a disease that has an impact on that goal, that outcome. So I try to have these real conversations as well to help people understand that we don't have any magic bullet solutions to overcome. There are tools, and we talk about the imaging as the diagnostic tool, and we talk about the surgery as the treatment tool, or the fertility or assisted reproductive technologies. But each of those has limitations with respect to what they can do. They all also have limitations with respect to timelines and cost. So a lot of people with endometriosis is a bit of a sad reality. They have to face that reality to be able to then reframe and redefine their goals. So that way that expectation and reality can hopefully be achieved.
Let's talk about surgery a little bit more. Tell us, what is the average wait time for endometriosis surgery in Ontario? And why is it important to have the right surgeon do your surgery? As you know, not every laparoscopic surgery for endometriosis is the right surgery for endometriosis. And also, let's talk a bit about the impact of endometriosis surgery on ovarian reserve, and how and when do you have that conversation with patients? I know it's a big question.
The first two, my answer is going to be somewhat controversial. So the wait time for endometriosis surgery ranges, of course, based on where you live and ease of access you have to a gynecologic surgeon. I would say my wait times for typical run-of-the-mill endometriosis surgery are around 6 months now. But in cases where we have bowel involvement, bladder involvement, where we have to arrange for multidisciplinary surgical teams, those wait times can extend beyond a year for sure, sometimes up to 2 years. And that has come about because We have limitations in access to the operating room. We have limitations with respect to coordinating care with other services who are dealing with their own patients. And often in the space of colorectal surgery, for example, they're dealing with cancer patients. And so we're facing some logistical barriers. Probably my surgical wait times on average are less than a lot of others because I am exclusively a gynecologist. I no longer practice obstetrics. And this is where the controversy comes. A lot of people who are ongoing practicing both obstetrics and gynecology are dividing their time. So many of those who have done minimally invasive gynecologic surgery training in Canada are still practicing obstetrics. And many of them love to practice obstetrics, and I'm not saying that they shouldn't, but they're not exclusively a gynecologist picking up lots of operating time because they have a whole separate patient population that they're helping. And so I think the wait time issue can be really optimized if our specialty decided that endometriosis surgery and gynecologic surgery was more relatively important with respect to allocation of resources, allocation of funding. And a lot of us who do endometriosis surgery, some of us who are still practicing in obstetrics, they actually might want to not practice obstetrics and only practice in gynecology. But the way that the funding model is and the way that the employment situation is for various hospitals, it actually doesn't permit that. So we need some big changes in how we devote energy, effort, and importance to endometriosis and gynecologic surgery in general. The wait times are very long. The second question, general obstetrician gynecologists trained in Ontario, in Canada, and around the world, generally speaking, do not have the surgical skill to tackle endometriosis surgery. Why? Endometriosis, like I said at the very beginning, impacts the pelvis and the abdomen in a way that it can impact organ systems that we as gynecologists are not traditionally trained to tackle. So my patient population, and actually endometriosis overall, has a really high prevalence of affecting the bowel. And so a general gynecologist who's done 5 years of residency training as a gynecologist does not have any surgical skill set or place touching the bowel. However, I've done advanced training, and many practicing OBGYNs in Ontario have done advanced training in minimally invasive gynecologic surgery where we learn how to handle the bowel. And in fact, some of us do our own bowel surgery for endometriosis. If you are a patient who is being told by your gynecologist, let's do a diagnostic laparoscopy, let's go in and see what we see, let's take out cleanup, often we hear, what we see, this is very risky. Because if the endometriosis is affecting any area that gynecologist is ill-equipped to handle, the bowel, the ureters, the bladder, they're not going to do anything about it. They're going to either leave it alone, they might do a little bit of ablation, and you will be incompletely treated. So finding the right surgeon is really key. And I'm not saying that a general OBGYN cannot do endometriosis surgery, because certainly people will learn how to do some of that in their residency training or beyond their residency training. They may find a mentor, they may attend courses, and they may develop that skill set. But using the tools that we have access to, and again, I'm going to reference the imaging again, we can help people figure out, you definitely need a minimally invasive gynecologic surgeon at a tertiary center where they have a collaborator in the colorectal surgery department because you have bowel endometriosis, versus you have a relatively normal looking pelvis with a couple spots of superficial endometriosis. You might be okay taking that risk, let's call it, having your surgery by a general OBGYN in community A, B, or C. And that wait time might be a little bit less. So we can use the imaging to help us figure out who might be the right surgeon for that patient.
Thank you. I know I got greedy. The third part was the ovarian reserve part.
So the ovarian reserve part, first and foremost, it's really, really essential for patients to know that endometriosis affects the ovarian reserve as a primary issue. And surgery to remove endometriosis does not necessarily fix the issue of the ovarian reserve. What it may fix is the active inflammation that endometriosis exudes onto the ovaries, whereby the egg quality could be further compromised. When endometriosis affects the ovaries in the form of an endometrioma, and we're thinking surgically to remove that endometrioma, we have to cut through the ovary. which means we have to cut through some normal ovary to get to the endometrioma, which means we're going to damage the ovary in that area. And the process of removing an endometrioma is actually quite challenging and quite messy. And there's bleeding that is common, whereby we have to use energy or suturing of the ovary to then stop the bleeding and bring the ovary back together. And all that can have a negative impact on ovarian reserve, which can potentially further make fertility issues worse. If surgery is going to be applied to somebody who has an endometrioma, I am really insistent that they have a really serious conversation about that freezing of eggs or embryos before the surgery. At least try. And then we do the surgery. And then if there are embryos, you do embryo transfer thereafter. Or, hopefully if we're doing fertility preservation and the concept of fertility is downstream, we use hormonally suppressive agents to help prevent the recurrence of that endometrioma until they're ready for the use of those eggs or embryos. But it's another reality that we have to face. We have to face it as the physicians and the surgeons, and the patients have to face it. There's no rainbows and flowers and sunshine when it comes to endometriomas and surgery. It's sort of a lose-lose in some ways.
Oftentimes I'll talk about it, right? It's almost like the chicken and the egg scenario where you have a person who is contemplating surgery and is planning for future fertility. It's like, do you freeze eggs and embryos first before surgery, or should you do it after? And again, just like we've said so many times in this conversation, it's a very individualized decision, weighing the pros and the cons. Because let's say, is there a really big endometrioma or is it small? Are we going to have issues potentially accessing those eggs? Meaning, at the fertility specialist time of retrieval, are they going to be able to get to all the eggs? And then there's this big question about egg quality. And I mean, frankly, that is something we could do a whole episode about. Briefly, we really can't assess that prior to going into a retrieval. And so is it better to get more eggs before surgery, but that maybe potentially are a little bit worse quality? Or is it better to have potentially less eggs post-surgery that may be a little bit better quality? I don't know how many times I said maybe in that, but I think that just underscores how difficult it is to really know what our next step should be when there are so many different avenues and things that can happen.
Well, I mean, like Dr. Leonardi said, that is the reality of the disease.
Absolutely.
We're lacking so much research in this space of endometriosis, fertility. And when you throw into the mix somebody who has symptoms as well, how to manage the whole scope of it is really challenging because we don't have great research in this space. And therefore, we don't have a lot of confidence in recommending certain things. And we've had this thread throughout regarding the individualized approach. One of the downsides of research and randomized control trials is it's still a single intervention applied to a population without that degree of nuance. So even if one day we do have more evidence, we'll still be having these incredibly uncertain conversations with patients because they may not be that exact patient that was studied in that particular research study. It's so challenging to have these conversations because we don't know what's going to work always. And all those factors of cost and timing and risk, everybody's going to be different in how they interpret them.
There is something else that I want to highlight for our audience. And this is a very classic scenario that I'm sure you're very familiar with. And this is a scenario where patients tell me they have been talking to the doctor that they have pelvic pain, and the doctor did an ultrasound, and the ultrasound was normal. Therefore, they thought they didn't have endometriosis. And then they go through a fertility journey, and they come to us. We send them to Sugo, or we send them to Care Imaging here with Dr. Zeni, and we do an advanced pelvic ultrasound. And of course, we now find endometriosis. So now let's talk a bit about the right type of ultrasound to diagnose endometriosis and how a normal ultrasound done in the community does not effectively rule out the presence of endometriosis.
For what it's worth, a normal ultrasound, even in my hands or in the hands of Dr. Zeni, who I know is doing the scans for you guys there, we cannot rule out superficial endometriosis. So we cannot rule out endometriosis. That is still the truth overall. But let's really come to the divide between the basic scan and the advanced scan. The basic scan is what we define as what's happening in community ultrasound clinics and hospitals and fertility clinics, whereby the structures that are assessed involve the uterus and the ovaries, and sometimes the fallopian tubes. As we've been talking about, endometriosis can affect any place in the pelvis. It can affect the bladder, the bowel, the ureters. It can cause adhesions. And in a basic ultrasound, none of that is actually being assessed for. If you don't look, you will not find. If you don't look and you don't find it, you cannot actually even have on your scan report find the line normal, because it's an incomplete assessment when it comes to an endometriosis perspective. But that is still currently the standard of care ultrasound that's being done around the province and around the world, truly. And me and many people that I'm working with are actively working to change this with respect to guidelines and education. And we are seeing steps. We have support through the Society of Obstetricians and Gynecologists of Canada and the Canadian Association of Radiologists to move this needle forward. The advanced scan, of course, we look at the uterus, we look at the ovaries, but we look at the bladder, we look at the bowel, we look at the ureters, we look at the mobility of all the structures in the pelvis in a way that allows us to understand whether there are adhesions or there are not adhesions. We're looking in all of these structures for deep endometriosis. And when it comes to superficial endometriosis, this is the type of endometriosis that's like a mole or a skin tag. It lines the surface of the skin of the pelvic cavity, which is called the peritoneum. And they're very small. They can be 0.5 millimeter in size. And we have to think, I'm now looking for superficial endometriosis. It has to be very active effort. And sometimes it does jump out at us because it can be pretty obvious on certain scans. But if we don't say in our head, I am now looking for this, it's not an active search. You have to be really intentional about it. And so we do that all the time. So our advanced scan, the reports, for example, they're usually 2 pages in length, much, much longer in detail. And when we do the advanced scans, or even our basic scans that we do, we're looking at the uterus and the ovaries with a really, really high level, sort of leading edge perspective. We're looking at adenomyosis using the morphologic uterine sonographic assessment tool. We're looking at the ovaries with the perspective of the International Ovarian Tumor Analysis tools. We're not just looking at those structures, but we're looking at them with a lens that's very advanced.
So it's definitely a much longer scan, a much more thorough scan, a much more involved ultrasound scan.
It can be longer. It depends a little bit on how much pathology there is. I can probably do an advanced ultrasound that is a normal ultrasound whereby there is no pathology, there's nothing to measure in 5 minutes. But, I'm me, and I've been doing this for many years now, and I do thousands and thousands of scans. When you start to get into certain degrees of pathology and you're actively capturing images and videos of those features and you're measuring things and you have multiple pathologies, these scans can be up to 30 minutes in length, again, in my hands. In some places around the world, there's a thought process that they should be scheduled for 45 minutes or even an hour. But again, we have to remember our context. Our government currently does not pay anything more for these scans. So what is being asked of us is to do more work, do harder things for the same amount of money as somebody who's next door not doing that same degree of work. For me, the goal is not money. For me, the goal is I want to do the right thing for the patient, and I want to push the agenda forward, and I want to make sure that we're getting as many patients advanced scans as possible. So, in some ways we take this hit financially, but that's fine. That's not an issue. But we still schedule our advanced ultrasounds for 30 minutes. I think they can be done in 30 minutes. But we've also refined our process. Like we have a reporting software that pulls in a lot of our numbers for us. So it really helps the efficiency of the entirety of the process.
Thank you so much for being here. This has been such a great discussion. I wish I could have you in my back pocket for every consultation, but I have nothing to complain about because we have Dr. Seni and he is amazing to work with. So Dr. Leonardi, looking ahead and looking at the future, how do you see ultrasound continuing to change the way in which endometriosis is diagnosed and managed within the constraint of the Canadian healthcare system?
To be honest, I have so much optimism for the evolution of diagnosing endometriosis. I have optimism because I know how much interest there is from healthcare providers across the province and across the country. I have people coming to my course from as far as the Yukon Territory and Newfoundland. I have people coming from even not Canada, but within our Canadian landscape, we have enthusiastic healthcare providers, sonographers, fertility doctors, gynecologists, radiologists who are coming to the course and coming to work with me to learn to then bring these tools and techniques back to their communities. I have so much optimism that within our country, access to imaging, in particular ultrasound for endometriosis, is only going to be increasing more and more. I also think that with the growing awareness in society, amongst our patient population, in schools, the knowledge of pelvic pain is not normal, period pain is not normal is growing, which means we're going to start to see people earlier in their journey. Me and my team are doing so much research right now on adolescents with pelvic pain and endometriosis. We have been using a relatively new probe that's as small as my finger to scan adolescents, either transvaginally or transrectally with their consent. And we're finding superficial endometriosis in 14-year-olds, 15-year-olds, 16-year-olds. We're finding some early signs of deep endometriosis in 18 and 19-year-olds. Like we've said already, whether you get this or not, we have no control over at this point in time. But what we do have control over is how we deal with it. And if we find it at a young age, we have an early opportunity to deal with it, to start to do treatments, to start to have conversations around what does your future look like at different time points. We're taking that life course model and trying to apply it to people when they get their diagnosis. We can get people to you much, much sooner and have these conversations when they have teeny tiny endometriomas and you have full access to the ovaries, or maybe they don't have endometriomas yet and the ovaries still have a perfect ovarian reserve and egg quality. So I'm really enthusiastic for so many reasons. The access is increasing. The ability for us to see all subtypes of endometriosis is increasing. The ability for us to scan people earlier in their lives and get diagnoses is advancing. We're seeing lots of hope. For me, the focus is always initially on diagnosis, but of course, when you know what's going on, then you have the opportunity to start to think, well, how do I do something about this? And my hope is that as we get better with diagnosis, more research into individualized management strategies is going to come forward. And then we're going to be able to have a little bit more clear conversations with our patients based on evidence and based on, actual research that's going to give us tools to help them. I hope that answers your last question. I hope you're hopeful. I hope the people who are listening in this podcast are hopeful, even though I know in the moment, sometimes things feel dark and dismal and hopeless, but there is hope for each individual when it comes to endometriosis and for the greater population of people with endometriosis.
Absolutely. Knowledge is power. And I think you said it perfectly. We can't control whether or not you get the disease, but we now have the tools to be able to diagnose it. And if we can diagnose it, then you have options that you wouldn't have otherwise if you didn't know what you're dealing with.
Thank you again so much for joining us and for giving us these fantastic insights into advanced ultrasounds and endometriosis. I have to say, these are some of my favorite conversations that we have on this podcast, where we kind of have this great cross-disciplinary conversation. Patients get to be privy to that and hear our take on things, from our perspective and your perspective as well. And we get to sort of bounce ideas off of each other and to understand where we are both coming from and really how we work together to provide the best care possible for patients.
Thank you for having me.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music by Mixkit. Life is a Dream by Michael Ramirez.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.